Hey guys, welcome to Clinical CPD Hub. This platform came from the idea that CPD shouldn't feel like something you have to squeeze in at the end of a long day. It should be practical, easy to access, and something you can actually apply in clinic straight away. This lecture is a free example of how we approach that. We're going to go through non-specific low back pain from an osteopathic perspective, and more importantly, look at how we can integrate the best evidence from across allied health into what we do every day. Welcome to today's lecture. Non-specific low back pain, an osteopathic approach and integration of modern evidence, module overview. This lecture explores the management of non-specific low back pain, NSLBP, from an osteopathic perspective, while integrating high-level evidence from physiotherapy, pain science, and exercise physiology. The focus is on bridging traditional osteopathic principles with contemporary evidence-based practice to improve patient outcomes through an active, individualized, and clinically practical approach. Learning objectives. By the end of this module, participants should be able to understand the multifactorial nature of non-specific low back pain, recognize the strengths and limitations of an osteopathic approach to NSLBP, interpret key Level 1 and Level 2 evidence relevant to NSLBP management, identify the role of exercise, education, and activity in long-term outcomes, apply an integrated clinical model to guide patient management. Module format, audio lecture, approx 20 to 30 minutes, optional clinical summary PDF, designed for practical, real-world application.
This lecture is part of what we're building inside Clinical CPD Hub. The goal is to make CPD more practical, more accessible, and actually relevant to what we do in clinic every day. Short, focused lectures that you can listen to on the way to work or between patients and apply straight away. All right, let's keep going.
Section 1, Introduction. Low back pain is one of the most common presentations we see in clinical practice. Across osteopathy, physiotherapy, chiropractic, and general practice, it remains one of the leading causes of disability worldwide. Despite this, outcomes are often inconsistent. Patients improve, then flare, then return again. And as clinicians, we can find ourselves repeating similar treatment approaches, often with variable long-term success. When we narrow this discussion to non-specific low back pain, or NSLBP, the challenge becomes even more apparent. By definition, we are dealing with a condition where a clear structural diagnosis cannot be confidently identified. In many cases, imaging findings do not correlate well with symptoms, and the traditional pathoanatomical model begins to lose its explanatory power. Hartvigsen and colleagues demonstrated that low back pain is best understood as a multifactorial condition, influenced not only by biological factors, but also psychological and social components. Hartvigsen et al., 2018. This has led to a shift in how we conceptualize and manage these patients, moving away from purely structural explanations toward a more integrated biopsychosocial model. For osteopaths, this presents both a challenge and an opportunity. Osteopathy has traditionally placed strong emphasis on hands-on care, structural relationships, and clinical palpation. These remain valuable tools within practice. However, the broader body of evidence across allied health suggests that optimal outcomes in NSLBP are often achieved through a combination of approaches, including education, movement, exercise progression, and behavioral change. Kassim and colleagues, in their clinical guidelines, emphasize that first-line management of non-specific low back pain should prioritize non-pharmacological interventions such as exercise, maintaining activity, and patient education. Kassim et al., 2017. Similarly, Foster and colleagues highlighted the importance of self-management and reducing unnecessary reliance on passive treatments. Foster et al., 2018. So the question becomes not whether osteopathy works, but how osteopathy fits within the broader, evidence-based management of non-specific low back pain. This lecture will explore that question in detail. We will begin by looking at what osteopathy does well in the management of NSLBP. We will then examine what the current high-level evidence tells us about effective treatment strategies across physiotherapy, pain science, and exercise physiology. Finally, we will bring these elements together into a practical, integrated clinical model that can be applied in everyday practice. The aim is not to replace osteopathic practice. Section 2. What osteopathy does well in NSLBP. Before we look outward to the broader evidence base, it's important to first acknowledge what osteopathy already does well in the management of non-specific low back pain. Because despite the ongoing evolution of evidence-based practice, There are several aspects of osteopathic care that remain highly relevant, and in many cases, align closely with modern clinical guidelines. One of the key strengths of osteopathy lies in its emphasis on patient-centered care. From the initial consultation, osteopaths are often trained to spend time understanding not just the patient's symptoms, but their broader context. This includes lifestyle, stress, movement patterns, and previous injury history. This approach aligns closely with the biopsychosocial model of care, which has been strongly supported in the literature as a framework for understanding and managing low back pain. Hartvigsen and colleagues highlighted that low back pain is rarely explained by a single structural issue, and instead reflects a complex interaction of multiple contributing factors. Hartvigsen et al., 2018. Another important strength is the therapeutic alliance. Osteopathic consultations often involve longer appointment times compared to other healthcare settings, allowing for meaningful communication, reassurance, and education. This relationship between clinician and patient has been shown to influence outcomes, particularly in chronic musculoskeletal conditions. Ferreira and colleagues demonstrated that patient expectations and the therapeutic relationship may influence pain and disability outcomes in low back pain. Ferreira et al., 2013. Hands-on treatment is, of course, a defining feature of osteopathic practice. Manual therapy, including soft tissue techniques, articulation, and high-velocity, low-amplitude techniques, can provide short-term symptom relief for some patients. Systematic reviews have shown that manual therapy may offer modest improvements in pain and function, particularly in the short term, although these effects are often comparable to other conservative interventions. Page et al., 2017. From a clinical perspective, this short-term symptom modulation can be valuable. Reducing pain, even temporarily, may allow patients to move more freely, engage in exercise, and build confidence in their movement. In this sense, manual therapy can act as a gateway to more active forms of rehabilitation, rather than being viewed as the primary or sole intervention. Osteopathy also places strong emphasis on movement. Assessment often includes observation of functional tasks, range of motion, and movement quality. While the interpretation of these findings should be approached with caution, particularly given the variability in movement patterns across individuals, this focus on movement provides a useful entry point for discussing activity, function, and rehabilitation. Importantly, osteopathic practice often encourages an individualized approach to care. Rather than applying rigid protocols, treatment is typically adapted to the patient in front of us. This flexibility allows clinicians to respond to changing presentations and incorporate different strategies as needed. When combined with an evidence-based framework, this can be a significant strength. However, it is also important to recognize the limitations. While osteopathy offers valuable tools, particularly in the areas of communication, hands-on care, and clinical reasoning, the broader evidence suggests that these elements alone are unlikely to produce optimal long-term outcomes in nonspecific low back pain. Manual therapy may reduce pain in the short term, but it does not consistently address recurrence. It does not build physical capacity, and it does not always influence the psychological or behavioral factors that contribute to ongoing pain. This is not a criticism of osteopathy. It is simply a reflection of the complexity of nonspecific low back pain, and it leads us to the next part of the discussion. What does the broader high-level evidence tell us about effective management strategies for NSLBP? Section 3. What the evidence says about NSLBP. When we step outside of discipline-specific approaches and look at the broader body of high-level evidence surrounding nonspecific low back pain, a consistent message begins to emerge. Across multiple clinical guidelines, systematic reviews, and meta-analyses, the management of NSLBP is no longer centered around identifying and treating a single structural cause. Instead, the focus has shifted toward promoting function, reducing disability, and supporting long-term self-management. Maher and colleagues in a landmark review highlighted that most cases of low back pain are nonspecific in nature and tend to follow a fluctuating course rather than a simple linear recovery. Maher et al., 2017. This reinforces the idea that our role as clinicians is not necessarily to fix a structure, but to guide patients through recovery and reduce the likelihood of persistent disability. Clinical guidelines consistently recommend that patients remain active and avoid prolonged rest. Foster and colleagues emphasize that advice to stay active and continue normal activities, where possible, is associated with better outcomes compared to passive strategies such as bed rest. Foster et al., 2018. This represents a significant shift away from older models of care that prioritized protection and avoidance. Exercise therapy has one of the strongest bodies of evidence in the management of NSLBP. Hayden and colleagues, in a systematic review and meta-analysis, demonstrated that exercise likely reduces pain and improves function in individuals with chronic low back pain, with effects that are clinically meaningful for many patients. Hayden et al., 2021. Importantly, no single type of exercise has been shown to be clearly superior, suggesting that the specific modality may be less important than factors such as consistency, progression, and patient engagement. This has important implications for clinical practice. It suggests that our role is not to find the perfect exercise, but to find an approach that the patient can tolerate, engage with, and progressively build upon over time. Education is another key component supported by the evidence. Providing patients with a clear, reassuring explanation of their condition and addressing unhelpful beliefs about pain and injury may improve outcomes when combined with active management strategies. Traeger and colleagues found that patient education, particularly when it addresses fear and misconceptions, can contribute to reductions in pain and disability in low back pain populations. Traeger et al., 2019. Pain science has contributed significantly to how we approach these conversations. While the exact mechanisms remain complex, there is evidence to suggest that helping patients reconceptualize pain as a multifactorial experience, rather than purely a sign of tissue damage, may reduce fear and improve engagement with movement and rehabilitation. However, it is important to note that education alone is unlikely to be sufficient, and appears to be most effective when combined with active interventions such as exercise. Manual therapy, including mobilization and manipulation, has also been widely studied. Systematic reviews indicate that manual therapy may provide short-term improvements in pain and function for some individuals with NSLBP. However, these effects are generally modest and often comparable to other conservative interventions. Page et al., 2017. As a result, most guidelines suggest that manual therapy can be considered as part of a broader treatment approach rather than as a standalone intervention. This aligns with a growing consensus across allied health professions. The most effective management strategies for nonspecific low back pain appear to involve a combination of education, movement, exercise, and behavioral support, rather than reliance on any single modality. From an evidence-based perspective, this reinforces a key point. There is no single technique, adjustment, or intervention that consistently outperforms all others. Instead, outcomes are more likely to improve when care is individualized, active in nature, and supported by clear communication and progressive loading. For osteopaths, this presents an important opportunity, not to abandon traditional approaches, but to integrate them within a broader, evidence-informed framework that reflects what we now understand about nonspecific low back pain. Understanding and behavior change. Pain science has significantly influenced how clinicians understand and communicate about low back pain. Rather than viewing pain purely as a reflection of tissue damage, modern models describe pain as a protective output of the nervous system, influenced by a range of biological, psychological, and social factors. Mosley and Butler have contributed extensively to this field, suggesting that reconceptualizing pain may help reduce fear and improve engagement, particularly when combined with active interventions, with movement and rehabilitation. Mosley and Butler, 2015. This is particularly relevant in patients with persistent or recurrent low back pain, where fear avoidance behaviors can become a significant barrier to recovery. Systematic reviews suggest that pain neuroscience education may improve pain and disability when combined with other interventions, such as exercise, although the effects appear to be modest when used in isolation. Lau et al., 2016. This highlights an important clinical takeaway. Education is not a replacement for treatment, but it is a powerful tool for improving how patients engage with treatment. For osteopaths, this aligns closely with the communication and patient-centered aspects of practice, but provides a more evidence-informed framework for how these conversations are structured. Exercise physiology, load, capacity, and return to function. Exercise physiology brings a strong focus on physical capacity, conditioning, and long-term resilience. In the context of nonspecific low back pain, this means shifting the goal from simply reducing pain to improving the patient's ability to tolerate load, movement, and activity over time. Hayden and colleagues highlighted that exercise therapy likely improves both pain and function in chronic low back pain, with consistent evidence supporting its use as a core component of management. Hayden et al., 2021. Importantly, this approach is not limited to isolated strengthening exercises. It often includes progressive loading, aerobic conditioning, movement variability, and return to meaningful activity. This is particularly relevant for patients who experience recurrent episodes of low back pain, where the underlying issue may relate more to capacity intolerance rather than a specific structural problem. From a clinical perspective, this introduces a shift in thinking. Instead of asking, what structure is causing the pain, we begin to ask, what is this patient currently unable to tolerate? And how do we gradually rebuild that capacity? Bringing it together. When we step back and look at these disciplines collectively, a clear pattern begins to emerge. Physiotherapy provides structure and progression. Pain science provides understanding and behavior change. Exercise physiology provides capacity and resilience. And osteopathy provides connection, symptom modulation, and a patient-centered framework. Individually, each of these has value. But together, they form a far more comprehensive approach to managing nonspecific low back pain. And this leads us to the next step. Not just understanding these concepts, but learning how to integrate them into a practical, repeatable clinical model.
Before we move into the final section, just a quick reminder. If you want more content like this, just a reminder that we have multiple course options, including full access to 35 hours plus of CPD content, subscription options where we release a new lecture every 14 days, as well as short courses inside the platform, all designed to be short, practical, and easy to fit into your routine. No long webinars, no wasted time. Just clinically useful information you can apply straight away. Let's finish up.
Section 5, the integrated osteopathic model. So if we take what osteopathy does well and combine it with what the broader evidence supports, the next step is to ask, what does this actually look like in practice? How do we move from theory to something we can apply in a busy clinic? What I'd like to introduce here is a simple framework for managing nonspecific low back pain using an integrated osteopathic approach. This is not a rigid protocol. It's a guide, a way of thinking that allows you to combine hands-on care, movement, education, and exercise progression in a structured, evidence-informed way. Phase 1, initial consultation, reassure, reduce, reframe. The first consultation is critical. This is where we set the tone for the entire management process. At this stage, our priority is not to find a perfect structural diagnosis. Instead, the focus is on screening for serious pathology, providing reassurance, reducing threat, and helping the patient make sense of their pain. As discussed earlier, most cases of low back pain are nonspecific and do not require imaging or a precise structural label. Maher and colleagues highlighted that over-medicalization of low back pain can contribute to poorer outcomes, particularly when it reinforces fear or dependence. Maher et al., 2017. This is where osteopathy already does well. We listen, we assess, we build rapport. From a treatment perspective, hands-on techniques may be used here to reduce pain and improve comfort. As we've discussed, manual therapy may provide short-term symptom relief, which can be useful in facilitating movement and engagement. But importantly, this is not the end point. It's the entry point. Alongside this, we begin introducing simple movement, not perfect movement. Not corrective exercises, just safe, tolerable movement that builds confidence. We also begin the process of reframing pain, helping the patient understand that pain does not always equal damage, and that movement, in most cases, is safe and beneficial. Phase 2, early management. Move, engage, build trust. As we move into the second and third consultations, the focus begins to shift. Hands-on care may still be used, but the emphasis gradually moves toward active strategies, encouraging continued activity, introducing simple exercises, and reinforcing positive beliefs about movement. Foster and colleagues emphasize that maintaining activity and avoiding unnecessary rest is associated with improved outcomes in low back pain. Foster et al., 2018. At this stage, compliance is key, not intensity, not complexity. We are building consistency. Exercises should be simple, tolerable, and easy to integrate into daily life. This may be as straightforward as walking programs, basic mobility work, or low-level strengthening. The goal is not to fix the patient in a single session. The goal is to build momentum. Phase 3, progression, load, capacity, confidence. As symptoms begin to stabilize, we move into the progression phase. This is where exercise physiology principles become increasingly important. The focus shifts toward progressive loading, improving strength, increasing tolerance to movement, and restoring function. Hayden and colleagues demonstrated that exercise therapy is likely effective in improving both pain and function in chronic low back pain, particularly when it is progressive and sustained over time. Hayden et al., 2021. This is where we move beyond symptom management and begin building capacity. Patients may be introduced to resistance training, functional movement patterns, and more demanding activities relevant to their goals. Importantly, this progression should be individualized. Not every patient needs the same level of loading, but every patient benefits from increasing their capacity relative to their current baseline. Phase 4. Independence and long-term management. The final phase is often the most overlooked, but it is arguably the most important. This is where we transition the patient away from clinician dependence and towards self-management. Education continues to play a role here, reinforcing that flare-ups may occur, but are not necessarily a sign of damage, and can be managed with the strategies they've developed. At this stage, the patient should feel confident in managing their symptoms, continuing their exercise, and maintaining an active lifestyle. This aligns with guideline recommendations that emphasize self-management and long-term activity as key components of low back pain care. Kasim et al., 2017. Bringing the model together. When we look at this model as a whole, a few key principles stand out. Hands-on care still has a role, but it is no longer the center of the treatment. Exercise is not just an add-on, it is a core component. Education is not optional, it shapes behavior and engagement. And most importantly, the goal shifts from short-term pain relief to long-term function and independence. The key shift. This approach requires a shift in mindset, from what technique should I use? What does this patient need right now? And how do I progress them over time? It moves us away from being purely treatment-focused and toward being outcome-focused. Section 6. Clinical Case Application. Audio script. To bring this model into a practical context, let's look at a simple clinical example. A 35-year-old male presents with non-specific low back pain. He reports a gradual onset over the past 3 weeks, with no clear mechanism of injury. His pain is worse with prolonged sitting and improves slightly with movement. He has experienced similar episodes in the past, typically resolving with treatment, but often recurring within a few months. He works a desk-based job and describes himself as not very active. He expresses concern that his back is weak and is worried about making it worse with movement. On assessment, there are no red flags. Movement is mildly restricted in flexion and extension, with some discomfort at end range, but no clear directional preference. From a traditional perspective, it would be easy to focus on local structures. But within an integrated model, we take a broader view. Initial consultation. The first step is reassurance. We explain that his presentation is consistent with non-specific low back pain, and that while the pain is real, it does not necessarily indicate significant tissue damage. As discussed earlier, most cases of low back pain are not linked to a specific structural pathology and tend to improve with appropriate management. Maher et al., 2017. We address his concern about weakness. Rather than reinforcing the idea that his back is fragile, we begin to reframe the concept toward capacity and adaptability. From a treatment perspective, hands-on techniques may be used to reduce discomfort and improve movement. As previously discussed, manual therapy may provide short-term symptom relief, which can be useful in facilitating engagement with movement. Page et al., 2017. However, this is only one part of the approach. We also introduce simple movement. In this case, this may include regular walking, gentle spinal mobility, and reducing prolonged sitting. The emphasis is on keeping things achievable and non-threatening. Follow-up consultations. By the second and third sessions, the focus begins to shift. The patient reports some improvement in pain, but still expresses concern about movement. This is where education and reinforcement become important. We revisit the idea that movement is safe. We normalize the experience of discomfort during recovery. And we begin to introduce more structured activity. This may include basic strengthening exercises, hip and trunk control work, and gradual increases in daily activity. Foster and colleagues highlighted that maintaining activity and avoiding unnecessary rest is associated with improved outcomes in low back pain. Foster et al., 2018. Hands-on care may still be used at this stage, but it becomes less central. Progression phase. Over the following weeks, the patient continues to improve. Pain levels reduce, and confidence in movement begins to increase. This is where we transition toward building capacity. Exercises are progressed to include resistance-based movements, functional patterns such as lifting, and increased loading through the spine. Hayden and colleagues demonstrated that progressive exercise is likely effective in improving both pain and function in chronic low back pain. Hayden et al., 2021. Importantly, the focus here is not just symptom reduction, but preparing the patient for real-world demands. Outcome. By the end of the management period, the patient reports reduced pain, improved confidence, and increased activity levels. More importantly, he no longer views his back as fragile. He understands that flare-ups may occur, but feels equipped to manage them. This represents a key shift, from reliance on treatment to independence. Key takeaway from the case. What's important in this example is not the specific techniques used, it's the progression. We move from reassurance to movement to loading to independence. Hands-on care played a role, but it was not the defining feature of the outcome. The outcome was driven by integration. So if we take all of this into account, what does this mean for us as osteopaths moving forward? Section 7, Conclusion. So when we step back and look at non-specific low back pain as a whole, a few key themes begin to stand out. Firstly, NSLBP is complex. It is rarely explained by a single structure, and it does not follow a simple, predictable path. As clinicians, this challenges us to move beyond purely structural models and consider the broader picture. Secondly, osteopathy still has a valuable role. Our ability to connect with patients, to provide hands-on care, and to guide movement remains highly relevant. They are important, but they are not enough on their own. And this is where the third point becomes critical. The strongest evidence across allied health consistently supports an approach that is active, individualized, and focused on long-term function. Kasim and colleagues emphasized that non-pharmacological interventions, particularly exercise and activity, should form the foundation of care in low back pain. Kasim et al., 2017. This does not mean abandoning osteopathy. It means evolving it. It means recognizing that hands-on care may provide short-term relief, but long-term outcomes are more likely to be influenced by movement education and progressive loading. And perhaps most importantly, it means shifting our role as clinicians, from someone who treats pain to someone who guides recovery. When we integrate the strengths of osteopathy with the broader evidence from physiotherapy, pain science, and exercise physiology, we move toward a more complete model of care, one that respects the patient, supports movement, builds capacity, and promotes independence. This is not about choosing one approach over another. It is about using the right tool at the right time for the patient in front of you. The future of osteopathic management for non-specific low back pain is not defined by technique. It is defined by integration, by our ability to take the best available evidence and apply it in a way that is practical, patient-centered, and clinically effective. Before moving on, take a moment to pause and reflect on how the concepts discussed in this lecture relate to your current clinical practice. Reflective practice is an important component of professional development, allowing clinicians to critically evaluate their approach and identify opportunities for improvement. Rather than moving straight through the content, consider taking 30 to 60 seconds between each question to pause, think, and relate the material to your own patient interactions. Reflection question 1. In your current management of non-specific low back pain, how much of your treatment approach relies on passive interventions compared to active strategies such as exercise, education, and progression? Reflection question 2. What is one change you could implement in your next consultation to better integrate an evidence-based, active approach into your osteopathic management of NSLBP? If this approach resonates with you, if you're interested in learning how to integrate evidence from across allied health into your osteopathic practice in a way that is simple, practical, and time-efficient, that's exactly what we've built inside our CPD platform. Short, focused lectures, delivered in an audio format you can listen to on the way to work, at the gym, or between patients. With a new course released every 14 days, designed to help you not just learn more, but apply more. If you'd like to explore that further, you can find more information in the links below. Thanks for listening.
Before you finish up, if you'd like to complete this as a formal CPD activity, including a short quiz and certificate, you can do that by clicking the link below and accessing the free course. Simply sign in, complete the quiz, and finalize your CPD record. It only takes a few minutes to complete. Thanks again for listening.